to hand you over to our moderator today, Dr. Jennifer Furin. Dr. Jennifer Furin is an infectious disease physician and anthropologist who has dedicated her career to providing health care for the sick and poor around the world. Dr. Furin has worked with patients who have MDR-TB since 1995 and has treated hundreds of children with the disease. She currently leads the Capacity Building Task Force at the Sentinel Project on Pediatric Drug-Resistant Tuberculosis and serves as a regular consultant and strong advocate for children and families affected by this disease. I will now turn you over to Dr. Furin. Thank you, everyone.
Hi, everyone. Good morning, good afternoon, and good evening. It's my pleasure to welcome you to what's going to be our final webinar in the Sentinel Project DRTB Training Network collaboration. We've had a really exciting year, and I have to tell you, I'm really delighted this morning. We're going to be going out with a bang for 2014. Many of you who've been able to tune in for our other webinars know that we've been talking about a lot of the issues and challenges facing children affected by drug-resistant TB, but one of the biggest problems is that we need more resources, more people interested in the problem, et cetera, and more attention to bring really the suffering of these children and their families to light. But one of the key challenges that we face that you've heard us talk about this year is that we don't even really have a good handle on how many children are actually sick with, infected with, and affected by drug-resistant TB. So it gives me great pleasure to introduce to you not only a very distinguished panel of speakers this morning, but a really wonderful and lovely group of people. Dr. Peter Dodd, who's currently a research associate in health economic modeling, which means he's really good at math. And he's at the University of Sheffield in UK. His training is in math and physics, but he's also done an incredible amount of work modeling infectious diseases. And he has a great background in tuberculosis, primarily in high HIV prevalent settings, but he's also done a lot of work with Imperial College and the London School of Hygiene and Tropical Medicine, modeling some community-based models for TB and HIV, including the well-known ZAMSTAR study. He's currently working on some user-friendly modeling tools to evaluate both the impact and cost-effectiveness of diagnostic algorithms for TB, pediatric TB, and he also works on hepatitis B transmission. Dr. Helen Jenkins is a statistical epidemiologist. She has her PhD in epidemiology from the Imperial College, and she also has her master's in medical statistics from the London School. She's currently based at Harvard right now, and she's using statistical techniques to really help us understand how infectious diseases spread, what the dynamics are, and the goal is to really make a programmatic impact by understanding some of the dynamics that Helen is working on. She's done incredible policy work looking at bovine tuberculosis. Helen is really a leader in understanding polio transmission, and she's done a huge amount of work on TB and child TB, so we're very excited to have her here. She's currently working on a KO1 award to investigate spatial heterogeneity of drug-resistant TB. And we're delighted that Helen and Pete are with us. And then finally, Dr. Andrea Cruz will be wrapping it all up and sort of giving us the take-home message. What does this mean for children around the world? And Dr. Cruz, much like Dr. Dodd and Dr. Jenkins, is also a multi-talented person. Who is both an MD with training in pediatric infectious diseases as well as in emergency medicine. And she also has her master's in public health in epidemiology and global health. So she's currently based at Baylor College of Medicine in Houston, Texas, where she directs the Children's Tuberculosis Clinic at Texas Children's Hospital. And this in the United States is actually the largest pediatric TB clinic that we have. So Andrea has great experience both in the US and internationally, and I think we'll be able to help contextualize a lot of what we're going to be hearing from Helen and Pete. So I apologize for taking the presenters' time by introducing them, but they really are an incredible group of people, and we're thrilled to have them here. So I'm going to turn things over now. I believe Dr. Dodd is going to be presenting first.
So surprise, it's Pete Dodd with a rather higher voice. No, so my name's Helen Jenkins. Thanks for the great introduction, Jen. I'd just like to apologize in advance. I have a bit of a cold at the moment, and there may be some coughing interruptions through my talk, but I'll do my best. So I'm going to talk to you today about some work that we did which was published, earlier this year, where we wanted to estimate the number of children that get sick with MDR-TB and TB every year. And the motivation for this project really came about back in 2011. And my colleague, Mercedes Becerra, at the time she was working on a different project, but she needed to know how many children get sick with multidrug-resistant TB each year. So she went to look for this number, and she looked harder, and she couldn't find it anywhere. And she realized that we have no idea how many children get sick with this disease, absolutely no idea. So she devised a nice method, which we'll come on to later, to calculate this number. But for that, she needed to know the number of children that develop all forms of TB each year, which should be an easier number to come up with. Oh dear, the crossing's out. It's got slightly askew here. We should have the MDR crossed out there. The idea being that the number of children that get sick with TB every year was also a number that was very hard to come by. So there were some estimates at the time, but they were generally quite out of date and unfortunately maybe not based on some of the best data, which we have better data now. And so we thought, well, maybe we can do something better than that. And then while we were working on this project, in 2012, the WHO put forward an estimate for the number of children that develop TB every year, and it was published in the WHO Global TB Report. And this is great. This is wonderful that this number is now forming part of the report each year and raising the profile of pediatric TB. And the number they put forward was around 490,000. And we felt slightly uncomfortable, actually, with one of the assumptions that was made. And that assumption was that case detection amongst children is the same as amongst adults. And the reason we felt slightly uncomfortable with this is as follows. Usually, case detection is done using smear microscopy. That's been the major diagnostic tool that's been used for a long time and is the main tool used in many countries in the world still. And that briefly, that requires producing a sputum sample from the lungs and then looking at this sample under a microscope to see if the bacteria are present. And the problem with this is that childhood TB is really rather different from adult TB. So children are more likely to have extrapulmonary disease. So if they don't actually have the bacteria in their lungs, this diagnostic will not be of any use at all. They're also more likely to have lower levels of bacterial burden, so the test will be less sensitive in them. And it's also harder to get testable sputum from these children. I mean, if you think logistically, trying to get a sputum sample from a baby or a toddler is very, very difficult. So we started by trying to get at this difference in case detection. And for that, we went back to a paper by Murray et al. From 1990. And in this paper, they presented data from the United States and from Norway, which have good surveillance for TB. And they looked at the percentage of all TB cases that you would expect to be smear positive, so using this diagnostic. And they found that in children aged under 15, you'd only expect about 10% of all TB cases to be positive with this diagnostic tool. Whereas amongst some of the adult age groups, sorry, all of the adult age groups, you can see that it's around 50 to 60%. So as our major data input at the beginning, we start off with WHO smear positive notifications by age. So these are available for around 70% of countries. And what we did was we scaled up these numbers using the data that I showed you on the previous slide to get an estimate of the actual number of TB cases that you'd expect. I'm sorry, can people hear me better now? I think there's some problem with people hearing me. Okay, I'll keep going and hopefully people will let me know. So as I said, we scaled up these numbers to get an idea of the actual number of TB cases that were occurring in each of these countries. We were able to sum up these totals to estimate the total number of TB cases occurring in each of these countries. And we're able to use that as the numerator, and then the denominator is our estimated total number of children that are being becoming sick with TB each year. So we're able with that to estimate the percentage of TB cases that are in children, just for those 70% of countries that have submitted WHO smear positive notifications by age. So the problem is, what do we do with the other 30% of countries for which we do not have smear positive notifications? Well, for that, we went back to a paper by Peter Donald from 2002. And he put forward a model which linked the percentage of TB cases in children with the total TB incidence per capita in a country. And he suggested that in places where you see a higher total TB incidence per capita, you actually see a greater proportion of the total TB caseload occurring amongst children. And so you can see on this graph, on the y-axis, we have the percentage of TB cases occurring in children, and on the x-axis, the incidence of TB, total incidence of TB in adults and children per 100,000 population. And you can see that one of the ideas he put forward here was that these countries marked with A, which have a lower TB incidence per capita, the typical population distribution in that country, you see actually a lower proportion of the population occurring in children, and therefore you'd expect a lower proportion of the TB caseload in children. And then on the other end of the graph, we can see that countries which have a higher TB incidence per capita are actually the types of countries which have a greater proportion of the overall population amongst children, and therefore a greater proportion of the TB caseload amongst children. So we said, okay, we'll take our estimated percentage of TB cases occurring in children for those 70% of countries, and we'll plot those against another data input we have here, which is the WHO estimated total TB incidence per 100,000. And the WHO estimate this number for every single country in the world. So we fitted our own regression curve to match that of Donald in 2002. And once we have this model, we're then able to estimate the percentage of TB cases in children for all countries in the world. So here's our graph, the equivalent to that of Peter Donald. And again, on the y-axis, we have the percentage of TB cases occurring in children. And on the x-axis, we have the total TB incidence per capita. And each dot is a different country. And you can see this middle line here shows our fitted regression line, and the other two shaded areas are showing our confidence intervals around this line. So we now have the percentage of TB cases occurring in children for all countries in the world. And then we need to multiply this by the total number of TB cases. And again, we use the WHO TB incidence per capita, multiply that up by UN population numbers, multiplied by our percentage. And we get the number of incident active childhood TB cases occurring in 1 year. And we estimated that globally, approximately 1 million children get sick with TB each year. So I'll just tell you how we then went on to estimate the number of children with MDR-TB. And what we did here was we did a systematic review where we wanted to identify all the studies that had estimated the proportion of children with MDR-TB and the proportion of treatment-naive adults with MDR-TB in exactly the same setting. So we identified 31 papers that had the data that we needed. And on the y-axis, you can see the proportion of childhood TB cases with MDR-TB, and the proportion of treatment-naive adult TB cases with MDR-TB is on the x-axis. So each circle represents a different study, and the size of the circle is proportional to the number of children that were tested for MDR-TB. And we were able to fit a weighted linear regression, so that's weighted by the number of children tested for drug-resistant TB. And we found with our regression that in fact the two measures are broadly the same within the same population. So another data input is the WHO have estimates of the percentage of adult TB cases with MDR-TB. And this is estimated with a variety of different methods depending upon the quality of data that individual countries collect. And we have our relationship between MDR risk in children and that in adults. And therefore, we can predict the percentage of childhood TB cases with MDR-TB in every country in the world. We multiply this by our estimated childhood TB incidence to give us the total number of children that get sick with MDR-TB each year. And we estimated that of those 1 million children that get sick with TB, around 32,000 of them actually have multidrug-resistant TB. And I don't really have time today to go through the various limitations in our method, but I would like to say that we see these numbers as very much being starting points, and we're doing further work at the moment to try and improve and refine these estimates. But it is really important to have estimates in the first place. And what it means is that we can now understand the magnitude of the discrepancy between what's actually reported and what we think is really out there much better. And this will enable us to better predict the resources which will be needed. So for 2012, around 349,000 children were notified to the WHO with TB. So we estimate that actually only 1 in 3 children that have active TB disease are actually being found. The WHO updated their estimate for 2012 to 540,000, but we still believe that this is an underestimate of the true value. Pete has kindly given me permission to steal his thunder slightly so that I can compare my result with his. You'll see that his is for the 22 high burden countries. But with a number of caveats, if we roughly scale that up to get a global estimate which will be comparable with ours, he has a number of around 800,000. And I think really with the various caveats and limitations in both our method and Pete's, there isn't really a huge difference between 800,000 and 1 million in the big scheme of things. I think the overall message is that we just aren't finding enough of these children. One thing that I find very sobering is how little we know about childhood MDR-TB. So when we looked at reports of MDR-TB in the literature, which spans 40 years, we found only around 600 to 700 cases reported, and that's around 2% of the total burden that we estimate occurs in 1 year. So we really don't know anything about how many children are developing this disease. At the beginning, I mentioned some differences between adult and childhood TB in terms of diagnostics. But it's also important to remember that in contrast with many adults, children that develop active TB, they've been infected really very recently, maybe in the previous few weeks or months. And they've almost certainly been infected by somebody very close to them, probably somebody in their home, somebody in their immediate family. And so we believe that most of this morbidity and mortality is wholly preventable. While I would say that in the long term, we do need a lot more investment in diagnostics and treatments for children, I also think that in the meantime, we have tools available to us that we can use. Better contact tracing to find those children, and also use of preventive treatment so that infected children can be treated and they don't develop active disease at all. Finally, I would just like to acknowledge my co-authors on this work and the funding that I received. And then I believe we're passing over to Pete. Thank you.
So what I'm going to talk about today is joint work predominantly between myself and Jen Seddon, who's a clinical epidemiologist at Imperial. And the goal of everything that I'm talking about today is has been nicely set up by Helen. So our different approach to getting around the problems that there are with pediatric notification data is not to use them. So instead of starting with the notification data in children, we're going to start with the notification data in adults and the modelled prevalence that WHO estimate is in adults. And then we're going to use knowledge about TB transmission and epidemiology to model how many kids we think are getting infected, and then knowledge about the natural history of disease to get an idea of what we think that implies the incidence in children is. So that's a two-stage modelling process. So there's that first stage, oops, my apologies. That first box there is a model to get the risks of infection from the adult prevalence estimates. And then we need another modelling stage to work out how many of those children are going to go on to develop disease. Now, a couple of things to say in passing is that we actually took two different modelling approaches to the risks of infection. And one of them was just looking at household transmission. I won't focus on that so much. And the other thing to say in the bigger picture is that we applied our approach to the 22 highest burden countries in the world rather than the whole world, although the 22 high burden countries probably have about 80% of the world's TB burden. So I guess a lot of you actually have come across Stieblow's rules that were formulated in the middle of the 20th century. And I want to point out two things about those. The first is that they're actually a model. So it's a very simple model, but it is nevertheless a model. And the second thing is that they actually contain two of the major ingredients in our modelling. So the first is a way of relating TB prevalence in adults to risks of infection. So that's the thing that's normally called Stieblow's rule, which is highlighted in red on that slide. And he also has a rule that is to do with the risks of progression. So his idea was that in adults, people had about a 10% lifetime risk of developing disease if they became infected. So the bird's eye view, which you probably can't make out completely, of the modelling logic looks like this. And all I really want to point out on this slide, which I'm going to step through in the following 10 minutes or so, is that the modelling stages that I talked about, the model of exposure and infection and the model of progression to disease, are these oval shapes in the diagram. And all these peripheral diamonds are the data and assumptions that are informing those models. So to begin with, the model of exposure needs something to drive it and something to act upon, and that means demography and TB prevalence. So the demographic data is relatively simple. That's just data on the number of children in different age categories. And then the TB prevalence comes from WHO's estimates. And you can see that actually they put out uncertainty ranges around their estimates, which is laudable. And one of the big points of the way we chose to approach this was to try and incorporate all of these uncertainties in each of the ingredients in our approach. So we've got the number of kids who are available to be infected. We've got the TB prevalence that's going to drive infection. The other things we need to know to turn that into a model of infection depend on what our approach is. So the first approach, which is the one to concentrate on, is basically an updated version of Stieblow's rule, which relates the risks of infection to the prevalence of TB in a community. So that graph on the left there is actually a representation of some data from a couple of reviews which looked at communities where there had been measurements of both smear-positive TB prevalence and the annual risk of infection. And actually the numbers that came out of those studies, which are more recent than the ones that Stieblow was looking at, give a slightly lower ratio between ARI and prevalence. And the way that's incorporated in the model is actually shown in that red line, which is a probability distribution which tries to represent the certainty of our beliefs around that quantity. So for our second model, which looked at only the household as a route of infection, you need a lot more information. So for starters, you need to know something about the household makeup in all of the countries you want to look at, so you know how many children are sharing with adults of different ages and that sort of thing. And then you also need an analogous layer of data on relating risks of infection if you share a household with a TB case. So that's what's going into our model of exposure and infection. Then you need to move on to the model of progression to disease following infection. So your risks of going on to develop TB disease if you're a child depends strongly on what your age is. And moreover, the type of disease you go on to develop, whether it's extrapulmonary disease or pulmonary disease, also strongly depends on age. So the information we use to inform this part of the model is largely based on a review by Ben Marray of the pre-chemotherapy literature. And you can see that for each age group, we've got a median risk, but we've actually got some uncertainty around that. Because as with the ratio between ARI and prevalence, we're representing each one of these quantities as a probability distribution around some value. So there are other things which influence whether you go on to develop TB disease, which are relatively common in the 22 high-burden countries that we were looking at. One of the things that's a common factor in the 22 high-burden countries is neonatal BCG vaccination. So most of those countries have quite high neonatal BCG vaccination. I think Nigeria and Afghanistan have lower coverages. Now, the protection against disease from BCG vaccination isn't perfect, and it isn't perfectly known. And moreover, it provides, or is thought to provide, better protection against extrapulmonary disease than pulmonary disease. So all of those things we tried to represent in our model. And then moreover, some of you maybe have come across this story about potential variation with latitude in BCG efficacy. So there have been studies on BCG efficacy from all over the world, and some people have argued that they show a systematic trend in protection by latitude, which, if you're hearing it for the first time, sounds remarkably odd, but the biological thinking behind that is that it correlates with the prevalence of non-tuberculous mycobacteria in the environment, which could influence the observed degree of protection from BCG in a couple of ways. So they could directly and detrimentally affect the immunogenicity of BCG, or they could actually generate their own cross-immunity to TB by infecting kids, and that just masks what you're seeing. So in line with each of those kind of broad possibilities, we pursued different modelling possibilities and had one where a proportion of BCG efficacy varied with latitude, and another where we just said, well, okay, we're going to fix it and not let it vary with latitude. Then the other thing that's important in some countries is HIV infection, and in adults, the relationship between HIV infection, even by CD4 count, and the increased risk of going on to develop TB disease after infection is well quantified. But for children, there's much less known, so we had to be relatively crude in our assumptions there. So that's all of the ingredients that have gone in. Given that, for every choice of parameter from these probability distributions representing our uncertainty, you can get an answer in each country for the number of children getting extrapulmonary TB, pulmonary TB in each age group. And you can run the model very many times in such a way that you build up an impression of what your outputs is that represents the uncertainty in your inputs. So to look at some outputs, this is maybe not the easiest graph to understand, but it's a comparison between notifications, which are the red dots, and model projected incidence, which are these sort of spermatozoidal shapes weighted around the central model estimate. And I guess there are three things that you can sort of see. I mean, the first one is that the substantial underreporting. So there's a gap between the notifications and the incidence. And we estimated a case detection ratio for these countries in children of about 35%, which is around half what the WHO estimate the CDR to be in adults. The other thing you can notice is that that degree of underreporting is probably more severe in the younger age groups, which makes sense clinically because TB can be harder to diagnose in that age category. And then finally, there's a reasonable amount of heterogeneity, in fact. So if you look at the top in Zimbabwe, the underreporting is much less than it is in Vietnam, according to our model. Our overall numbers for these countries, well, one of the reasons we were interested in a household approach to exposure and infection is because you can estimate how many children are living with a TB case. And that's important because, as Helen was saying, these children in principle are traceable and are children that you can intervene upon and try and prevent disease or treat disease if they already have illness. And we estimated about 15 million children were living with a TB case. We also estimated the incident number of TB infections and the number of children who are living with a latent TB infection. And then finally, the comparable number with the quantity Helen was producing is the incidence of TB disease, which came out for us in the 22 high-burden countries of around 650,000 cases. And you can see that our uncertainty intervals here are large. You might notice that actually the relative uncertainty in, for instance, the incidence of TB disease is larger than it is for the incidence of infection. And that's because there's this extra modeling stage in going from infection to disease, which brings with it more uncertainty. Looking by country, it's striking the proportion of burden that's carried in India at around 27% of the burden in these 22 high burden countries. And finally, we also looked as an output of our model at the relationship between TB incidence and the proportion of TB incidence that's occurring in children. And indeed, we did also find a positive correlation. But I think one of the interesting things on this slide is that some countries outlie that. So Zimbabwe and South Africa are notable for being somewhat across from the other countries, and they're peculiar, if you like, because they have such a high association between HIV and TB in those countries, which doesn't work in the same way for children. So just to quickly sum up and make a few comments, the very quick summary of what I've gone through here is that we were using a mathematical modeling approach to estimating the burden of TB in children, which basically didn't use the TB notification data in children at all, but tried to work from the data in adults using an understanding of epidemiology and natural history of disease. Now, there are pros and cons of this sort of an approach compared to Helen's cleaner approach, I guess. We need to make more assumptions, and each of those brings with it uncertainty, which reflects in our outputs. And arguably that introduces more frailty because with each assumption there's a possibility for bias in the data you're using, or misinterpretation, or just making a mess of things. On the bright side though, I mean, just because something's uncertain doesn't mean you can't work with it. And in actual fact, you can analyze the sources of uncertainty to try and work out which of your bits of ignorance are most important for certain quantities or for making certain types of decision. I think this kind of modeling allows you to get more answers. That's sort of what you buy with all this uncertainty. So we get age disaggregations and disaggregation by disease type with this method. And the other thing about mechanistic models is, at least for the bits of mechanism that you've included, you can also ask questions about what would happen if you intervened and changed the bit that you're modeling. But just to finish off, I think the public health message from this is exactly the same as Helen's, that there's a substantial and probably underestimated burden of disease in children, and a lot of it is probably preventable.
And it's sort of entitled Measuring the Chasm. When we think about childhood TB, we often think about it in terms of sort of the iceberg analogy, where there's only a small part of the total mass is above the surface. And typically, we think about this in terms of TB disease, where we know underreporting is a massive problem. But I think that these papers also allow us to measure two other things, namely MDR-TB, and then really the burden of latent TB infection in the population, which hitherto has really not been measured at all. So when I think about chasms in our knowledge of childhood TB, there are many that I could have picked. I chose to pick these three that were relevant to these two papers. The first is the sort of the burden of TB infection. It's not reportable. The most commonly thrown out number is 1/3 of the global population. And while this is often cited, it's rarely referenced back to an individual citation. And we don't have much in the way of national level data. This is certainly true even for low incidence industrialized nations such as the United States, where most of our data come from certain cohorts that are really not generalizable to the rest of the population. For disease, obviously reportable disease, but there are clear reporting gaps. Until the last few years, we really didn't have disaggregated pediatric data. And the numbers that we had, frankly, some of the times didn't seem to make much sense. So for example, a very large, very young population in a country like Nigeria only reported about 1% of all TB cases in children, which simply is not biologically plausible. And when it certainly came to the arena of children who are co-infected with HIV, those data were almost impossible to find. When it comes to MDR-TB, there are going to be clear reporting obstacles if you link reporting only to microbiologic confirmation. So if the child's only access to second-line medications is if they have a positive culture themselves, as opposed to sort of cultures by proxy, which we use all the time as far as household members, then that's going to clearly limit reporting. Again, there were few disaggregate pediatric data. And a lot of this, of course, stems from the diagnostic limitations that are faced by many high-burden nations. So how do the numbers help me as a clinician? Well, while we knew we were underreporting disease in children, we didn't really have any estimates of infection. And how does this impact us as far as our long-term goals? Well, it's pretty much impossible to benchmark what you cannot adequately measure. And I think that by raising the specter of the burden of TB infection on the global communities, especially in the high-burden nations, we also raise awareness of prevention opportunities and allow for countries to potentially estimate, if they want to address this problem, what resources might be necessary to allocate toward that goal. When you think about infection prevalence, like I said, often cited, rarely referenced, 1/3 of the global population. This is a number that's been appearing in the TB literature for many years now. And then it seems like if that's actually an accurate estimate, we should see probably more cases of TB disease than are currently reported. We know that TB infection is not reportable in most settings. And the estimates with which I'm familiar, which are the US estimates, generally are from non-generalizable cohorts. So probably the best population-based estimate are actually from military recruits at the time of World War II, the last war with US military involvement, where military involvement was sort of very equitably distributed among socioeconomic statuses, but also at a time when our military was segregated. Studies from nurses are commonly reported, but again, not a generalizable population, and neither are recent immigrants to the US, who often have more financial wherewithal than folks who do not have the financial capabilities of emigrating. One of the things that I liked most was actually the estimate of infection incidence. And I think this is important because we know that for children, about half of their lifetime risk of progression to disease is in the first 1 to 2 years after infection. And so if it's possible to figure out, at the very least at the population level, where you might best allocate your resources, you might be able to identify in individual nations cohorts of children who would benefit most from preventive therapy. And I say this because children who are infected, with few exceptions, would benefit from preventive therapy across the board. But we know that there are barriers to operationalization of INH preventive therapy. So in places where widespread use of IPT is not possible, these numbers might actually be able to guide programmatic management to enable targeting of resources to the highest risk children. And I'm sorry, is this a bit easier to hear me now? Okay, thank you. As far as MDR-Infection, there are really no current estimates. We have few data on optimal treatment regimens, both in terms of efficacy and in terms of tolerability. There was a very interesting case in California this year of a school teacher who had MDR-TB and many of the children in her classes had evidence of TB infection. These children were treated in some cases with a combination therapy of a fluoroquinolone and a second line, or in either ethambutol or pyrazinamide. And while the vast majority of children tolerate first-line TB medicines very well, the number of side effects that we're seeing among this cohort of children was startling. And it really led you to realize that, while we assume tolerability for medications in the pediatric age range, that's sometimes not a valid assumption. Because of the lack of data on efficacy, there are few children who have MDR-TB infection who actually receive treatment. And when they do receive treatment, their regimens very understandably are tailored to the source case susceptibility patterns, which leads to very heterogeneous regimens that really effectively precludes comparisons. And so one of the questions I had from reading these two papers again back to back was, could you use data from both of these papers to potentially model the burden of MDR-TB infection in this population? And would this then potentially be an impetus for clinical trials? As much as I would love to do clinical trials on this, as a US clinician, it's impossible for us to recruit adequate numbers of patients in my setting. So I've been focusing quite a bit on prevention. I'll get to disease momentarily, but focusing on it because I think it's an important backdrop, and I think that there are lessons that can be learned from TB control in low incidence nations that are actually applicable outside of our borders, despite the sort of obvious issues with generalizing things across the resource gradient. And one of those is the question of, how did TB high incident nations become low incident countries? And this is obviously in the pre-HIV era. So when we look at the history of TB for example, some of the great early epidemiologic studies of TB were actually from Scandinavian nations, which we would never think about in the modern era. And something equivalent is what happened in the US, which at the beginning of this graph actually includes data from the pre-World War II era, where the case rates were already dropping, but started off at 100 per 100,000. And then the first era that's listed here relates to the use of the first oral TB agents, and then the second era relates to the use of isoniazid. And while clearly the reduction in part in the pre-chemotherapeutic era was secondary to societal infrastructure changes, better nutrition, etc., the more rapid decline that we've seen in the US over the last half century, almost the last century, has been really a combination of active surveillance and emphasis on prevention of therapy. And it wasn't until the late 1960s, actually, that the United States fell into what the World Health Organization considers a low incidence country. So this is the schematic on the left is actually talks about sort of looking at children as sentinel events in the community, and the diagnosis of TB in a child should trigger a search for an infectious adult who's been around that patient, and looking at sort of the concentric circles approach that we often use epidemiologically. And the schematic that's on the right illustrates the fact that it's impossible to take care of children with TB in a vacuum. The adequate care of our kids who have TB is a very multidisciplinary collaboration, not only between clinicians, but with our public health partners. The paragraphs on the bottom of the slide are of a much more recent study looking at contact investigations of patients with MDR and XDR TB. And what they found was that at baseline, if they looked among a very large cohort of household contacts, about 2.5% of those contacts had active TB at the time the index case was diagnosed. And if you follow the household contacts who started off asymptomatic, a sizable proportion of those children, or those contacts, developed disease within the 4-year follow-up period. When we look at these references, the top reference is from Catherine Sue, who was one of my mentors here in Houston, and it was actually published the same month that John F. Kennedy was assassinated. The second reference is actually from Mercedes and her colleagues in Boston that was published just a couple years ago. So you can see almost 50 years apart, the same methodologies hold true, but the question is, how do we do a better job of operationalizing this in the settings in which it needs to be operationalized most? When we talk about TB disease, we know that about a third of all cases are reported, and I think in part it's because of sort of this issue. So there are many places that children can fall out of the system. Not all children who are symptomatic present to medical attention. Not all children who present are diagnosed by their physicians or healthcare workers. And certainly we know that there's a huge breakdown between the children who are diagnosed and those that are reported. And I put the children who are confirmed cases in a smaller font, just recognizing the possibacillary nature of childhood TB and the fact that we rarely have microbiologic diagnosis for our children. We know that in countries who are reliant upon smear microscopy, they definitely underestimate, we think they underestimate the numbers of cases in children. And conversely, we know that in countries where more adults are diagnosed who are smear negative, a higher proportion of the total cases reported in that country occur in children. So from the standpoint of disease estimates, better numbers really help us quantify the unmet needs for diagnosis and treatment. Is this an issue of educating first-line healthcare workers so they're more cognizant of the various manifestations, of the protein manifestations of TB in childhood? Can this be used as an argument for augmented laboratory support? So not only for the tests that are done in the children, but how do we do a better job of acquiring those specimens in resource-limited settings? TB and HIV in children, clearly even harder to measure than in immunocompetent children, and perhaps not surprisingly, historically it's gone almost entirely unmeasured. It is important, and Pete and Helen alluded to this, is that with the current IPT guidelines, most of these cases really would represent preventable cases of disease. And so by having better numbers, you can benchmark how we're doing as far as IPT, and then think about, clinical trials. How would we minimize adverse events, particularly with a host of drug interactions that we see between TB medications and antiretroviral therapy? And could you have shorter course regimens to minimize, again, the duration of exposure for these children? MDR-TB estimates, we know there are huge disparities in reporting. When you look at MDR-TB maps, there are entire countries that are unable to furnish data for these because of diagnostic limitations. And you can see limitations resulting in over or underreporting in either direction. So you can have underreporting if no cultures are obtained. So for example, there are some countries who only have the capacity to do sputum smears or sputum cultures in patients who failed 6 months of first-line TB therapy. And if these patients don't survive beyond 6 months, you might have missed a case of MDR-TB. Conversely, in countries who can only utilize smear microscopy, you're going to over-report cases of MDR-TB or of clinically suspected MDR-TB if you're not able to differentiate between non-tuberculous mycobacteria and MTB. So better numbers would help us with contact tracing, potentially be an impetus for trials looking at duration of therapy and the number of drugs needed. We know that because kids have possibacillary disease, do they really need 5 to 6 drugs for a 2-year period? Or if you have a child who has relatively minimal lung disease or disease elsewhere, would that be a child who might be potentially, their disease might be amenable to a shorter regimen or regimen with fewer drugs? We know we have few pharmacokinetic information on the use of second and third line medications in children, and we know that certainly for first line medications, children and adults metabolize these drugs differently and different doses are required. And finally, there's always the issue of pediatric friendly formulations. So it's great to have drugs. It's even better to have drugs that our kids can have a hope of handling. So how do we operationalize this? Well, so one of the things that we've thought about is adding childhood TB contacts to the TB case card. It enables you to actually implement IPT for at-risk contacts if you know who those children are. And from an epidemiological standpoint, it allows for linkages to source case susceptibilities, which might not otherwise happen. And I think one of the keys is to really try to integrate TB services into existing maternal and child health services. We need to target resources to venues where children are already seeking care. And this is particularly the case for HIV co-infected children who in many countries have a clear medical home, but that medical home is often very separated from the national TB programs. So would it be possible to decentralize some of this and try to embed the services in areas where children are already seeking medical care? So in conclusions, yes, these estimates differ. However, there are numbers that we can look at where we had no numbers before, and it serves as, it serves as a way for us to benchmark what we're doing. It might enable us to increase programmatic resources, not only for TB disease, but to think about how do we better target TB infection. But really the idea that we're able to benchmark because we have some sense of where we are right now, I think it's a huge step for us in the pediatric TB community. Thank you.
Great. Thank you so much to Dr. Dodd, Dr. Jenkins, and Dr. Cruz for a fabulous presentation, incredibly thought-provoking as well. I see there are a couple of questions that have come up, and I agree with the comment that this was a really great tool for advocacy. Some of the participants said it would be nice to see the effective interventions on some of the modeling, and while recognizing how complicated some of these modeling exercises were, I think it could be a great next step that could help us show the impact of doing some of the things that Dr. Cruz mentioned. There's a question specifically to Dr. Cruz about expert and the use of expert technology. So Andrea, I'll let you take that question if you have a chance.
Absolutely. So I think that expert is going to be a huge boom as far as replacing smear microscopy, where the sensitivity is clearly orders of magnitude better than smear microscopy, and frankly is less user operator dependent. I think that it's no way, shape, or form should it replace speed or culture, because even if you know a child has MDR-TB, you still need to have conventional culture methodology to figure out what drugs you can then actually use in that patient. And I think that it would certainly increase awareness of MDR-TB if that were able to be rolled out. I think the rate limiting step in that is that it can't be used as a standalone feature. It does really need to be linked with doing a better job of obtaining specimens, adequate specimens for culture, which is incredibly challenging, especially in our young children.
Great. Thank you so much, Dr. Cruz. I see there are some other questions coming up about operationalizing some of these issues, and I'm afraid we're going to have to take those offline. But I really do just want to thank our speakers. It's been incredibly thought-provoking, and I think it also shows us how much work we still have ahead of us trying to identify children with TB and drug-resistant TB and get them the appropriate care that they needed. And that they need. I think also to mention is that even if children are not infected or becoming sick with drug-resistant strains of TB, even a child who's simply living with a parent or a caregiver who has drug-resistant TB is going to be impacted by the disease in terms of, potential loss of family income, potential food insecurity, et cetera. So, they're such a vulnerable group, our children, and I think we need to think about how best to serve them on all these levels. In closing, I do just want to mention that the series that we've had with the Sentinel Network through the DRTB Training Network has been very exciting and wonderful. And what we really hope is just the start of a larger conversation for all of us to have. One of the things I've enjoyed most about working in the pediatric world is that I feel like as far as TB and drug-resistant TB, we really are a great community. And that each of us cares very much about the disease and is each working in our own way towards making a difference in the lives of these children. And I think together, our collective action and spirit has been a real inspiration for me. And so I did want to let people know who are going to be able to be in Barcelona that on the evening of Tuesday, October 28th, the Sentinel Project is going to be hosting a network meeting and reception at the Hotel Diagonal Zero, which is right across the street from the conference venue. If you're there, please come by. It'll give you a great chance to interact with and follow up on some of the questions with people like Dr. Cruz and Dr. Jenkins and Dr. Dodd. We'll also have speakers from the other Sentinel sessions, including James Seddon, Simone Scoff, Tony Garcia-Prats, myself will be there. And it's just a wonderful chance, I think, for all of us to come together to continue thinking about how we can collaborate and leverage our collective efforts to really make drug-resistant TB no longer a problem on any level for children around the world. So I thank everybody for their time and attention, and I'll turn it over to Evgenia to give the final closing and a special big thanks to our speakers today.